Hi, everyone. Welcome to this Colorado Cochrane affiliate webinar. My name is Ben Harnke, and I'm a research informationist here at the University of Colorado Strauss Health Sciences Library on the Anschutz Medical Campus in Aurora, Colorado. I'll be running the Zoom aspects of this meeting. Everyone feel free to type questions into the Q&A section or the chat. If you type in the Q&A, only the hosts can see the question. This session is being recorded, and the recording will be made available at the link I'll put in the chat here shortly. You will also receive an email about upcoming Colorado Cochrane affiliate webinars. The next one will be May 22nd at this same time. I would now like to introduce Julian Higgins, Professor of Evidence Synthesis, and Deborah Caldwell, or Debbie, Professor of Epidemiology and Public Health, both at the University of Bristol in the United Kingdom, which is 4 p.m. there right now. So thanks for getting on kind of late. They're going to speak to us today about their first year experience with the new evidence synthesis program at the National Institute for Health and Healthcare Research. And with that, I'll turn it over to Julian and Debbie.
Thank you very much, and thanks for inviting us to talk about this this new group that we've established in Bristol. I'm going to give a bit of background to the group, which is one of 9 around the country, and we'll tell you a bit about what the groups are generally doing and how we're doing it in Bristol, and what projects we've been working on so far. And Debbie and I will alternate between us, I think, about 4 times, so I hope that goes smoothly enough. So it began in January 2022 when NIHR launched this call for evidence synthesis groups around the UK. And they were looking for groups that could do evidence syntheses of various types, that had the methodological skills to do reviews of various sorts and various topic areas, and all sorts of topic areas in healthcare, public health, and social care. And they ran a commissioning process that was really quite transparent, and they published minutes of the results of the first stage. You can see here that was discussed in April 22, and they listed the shortlisted and the non-shortlisted applications. And then we applied in a second stage with a much more detailed application. And again, a shortlisting committee made some decisions in November 2022 and decided to fund 9 groups around the country to host these evidence synthesis groups. And my glasses are just broken. Little screws have fallen out onto my lap. Let's put that over there. And they began life in April 2023. Coincidentally, the day after funding ran out for the UK-based Cochrane review groups. So I think you can draw your own conclusions about what happened to the money they were using to fund Cochrane in the UK from that. Although there's been nothing said about that explicitly. I've got a spare pair of glasses. So this was the announcement a few weeks after we actually began work. So it was quite a substantial investment of £22.5 million, which is £2.5 million into each of the 9 groups. Yeah, I'll pass over to Debbie at this point.
Thanks very much, Julian. So as Julian's mentioned, there were 9 ESGs that were funded from the call, and we've done a little map here of where all of those 9 groups are, highlighting Bristol in red down at the bottom. So they were funded across all 4 of the nations of the UK with a remit to generate high quality evidence syntheses, but not just from an academic perspective. It's very, very key to the ESG enterprise is that they're responsive to inform policy and practice, so the needs of our policymakers and our decision makers across the UK. The ESGs, the topics that we receive mirror the remit of NIHR, so that can be healthcare, public health, and social care. They also wanted the ESGs to work together collaboratively to develop best practice in reviews, but also with this embedded methodological development and the innovation around methods in systematic reviews. Next slide, please, Julian. So each of those 9 groups is structured in slightly different ways. You might have seen on the previous slide that some of them are multi-institution ESGs across one or more academic institutions in the UK, and others are based in single institutions like Bristol's is. So on the left-hand side of this graphic is the academic team in Bristol ESG. And I'll give you a little bit more detail on us in the next slide. You can also see that we've currently got a team of 4 dedicated systematic reviewers. Now they're the people who are doing the daily nuts and bolts of the systematic reviews that we're commissioned by NHR to do. And we also have a dedicated information specialist working with us too. So on the right-hand side of the graphic are our real-world team of public contributors. We have 2 public contributors who support the ESG. And we also have practitioners across social care, public health and healthcare, policy advisors and experts in maximising the impact and the reach of any of the reviews and our research that comes out of our ESG. Now, that team of real world people also form our advisory board, and we meet with those every 6 months or so as a I guess as a bit of a steering group, but also they, along with our academic collaborators, help to identify any topic experts to support any of the reviews for which our academic team might not have the expertise. However, our academic collaborators, a lot of those acronyms at the bottom left there probably won't mean very much to you, but across those academic collaborators, we have public health, primary care, social care, health behaviour change, and translational research expertise as well. And also our colleagues in the Bristol Technology Assessment Group form our overall academic team. Next slide, please, Julian. But going into a bit more detail now on the senior team in our ESG. So Julian and I are co-directors. And we need to be able to take on any kind of review, both in terms of methodology, be that qualitative or quantitative, but also in terms of those 3 main topic areas: public health, healthcare, and social care. So looking at the academic team in greater detail, we each take on leadership in one of those key areas. So you can see that Julian is our lead for evidence synthesis methodology and statistics, and I lead on the public health topics. We're then also supported by Jelena and Andy. So Jelena is also an expert in systematic review methodology, but her key role within the ESG is in dissemination and knowledge mobilization. The NIHR were very keen, as I mentioned on the previous slide, that our reviews are as impactful as possible. So we have a dedicated knowledge mobilization lead. They're also very keen that we ensure that we have strong public contributors and involvement, both in the ESG in general, but also for each of the specific reviews. So Andy and Jelena are our senior leads for each of those 2 areas. We're further supported in terms of methodology and topic expertise by Hayley Jones, whose area of expertise is in the statistical synthesis around diagnostic test accuracy. Sabina, who's our health economics expert. Geraldine, whose expertise is in evidence synthesis in social care, and Christy, whose expertise is in primary care and qualitative review methods. Next slide, please, Julian. So by now, I think you know that the evidence synthesis groups are funded by our National Institute for Health and Care Research, but specifically, the part of NIHR that they're funded by is the evidence synthesis program. And I'll now just have a few slides outlining how that commissioning process between the ESGs and the evidence synthesis program, how that's been working. So ESP fund research that identifies, evaluates, and combines data from existing research studies. So they're an evidence synthesis program, as their title suggests. And the key there is that they summarize, well, their remit is to summarize the best evidence on effectiveness and cost effectiveness of interventions and tests. Just again, with this focus on decision making across all 4 nations in the UK. So the way that they work is policymakers and the National Health Service, charities, patient groups, professional groups, and so on, can go to the evidence synthesis program with specific research questions, but also ESP reach out to those decision makers as well, such that the questions that are coming into the ESGs are policy and practice relevant. There's also an annual opportunity for ESGs to propose our own topics. We think, you know, we're only just starting in our 2nd year. We think that that's an annual opportunity, but we'll have to watch this space to see if that is the case. And once those topics are proposed, they're reviewed and prioritized by the ESP's advisory group. So there's a prioritization process that happens within NIHR as well for these topics, and then they're allocated to the ESGs. Next slide. So approximately 3 to 5 evidence syntheses are allocated to each ESG per year, and that will be over 5 years. So the 5-year funding period that each of the ESGs is funded for. So the key is that these projects can be taken on promptly by each of the groups. And because they have this policy and practice focus, they require a quick turnaround. So that contribution can be made in a timely way. So we've mentioned that they can be any methodology, systematic reviews, scoping reviews, living reviews, qualitative, quantitative, mixed methods, realist, economics. It covers a really wide remit in any of those topic areas that we've mentioned. Next slide, please. So this isn't an official NIHR slide. This is a slide that Julian and I have put together to give you an overview of how this process has been working. So as I mentioned, first thing that happens is the topic identification, and it can come from lots of places, the health service, charities, professional, patient groups. They've also been coming directly from UK central government in London, Westminster, but we also have devolved governments for each of the 4 nations of the UK. So the Scottish government, the Welsh government, and the Northern Irish Assembly can also propose topics, as indeed can our regional governments. They're suggested down to the next layer, to the evidence synthesis program at NIHR. And as I mentioned, the prioritization group, the ESP prioritization and advisory group, can be called on to prioritize those topics and feed back to the ESP, at which point they are allocated to the ESGs. We're going to give you an outline of some of the projects that we've been working on. And this 5-point list has been generated from that experience of the projects that we've worked on to date. And after the projects are allocated to us, we very often need to refine the research question because it's a topic that's been proposed, not necessarily a specific question. So we need to agree that brief and meet with the decision makers or stakeholders who have proposed the topic, just to make sure that we're all on the same page. Then the ESG scopes the literature and submits an initial project outline for the type of review that we think is needed to answer the research question that we've agreed with the stakeholder. We also have to submit a cost estimate back to NIHR ESP. And I'll explain how we do that in a couple of slides. And you can see that there's kind of a bit of a circular, well, there's a possibility of needing to go back to the stakeholders if we don't quite get that project outline. If it doesn't quite meet their needs, there's a process of refinement that goes on too. Then once that's all settled, we finalize the outline and the costs. And from that point onwards, it looks much like any systematic review project in that we write a protocol and it's uploaded and registered to Prospero for example, a systematic review registration database. Next slide, please. So the way that the costings are done for the evidence synthesis program is using what are called person working days. So each ESG has an annual allowance of 1,100 person working days. And just to give an illustration of what that looks like, these are not set in stone, that there is flexibility. So a systematic review might take anywhere between 4 and 12 months, and the anticipated person working days for a systematic review are between 160 to 400 person working days. So as we're going through that outline process and working up the outline and scoping the literature, we're mindful of the resources that we need to take account of. Next slide, please, Julian. And the other part of the ESGs, as well as that applied rapid response type of enterprise, is that the ESP, NIHR Evidence Synthesis Program, were really keen that we had a strong methodological focus within the ESGs. So that we can continue to innovate and be at the forefront of methodological developments in evidence synthesis. So to facilitate that, they set up 4 cross ESG methods working groups. So that brings together the 9 ESGs. We have co-leadership of 2 of those methods working groups. I co-lead the studies within a review methods group with Mike Clark, and Andy leads the public involvement and engagement methods group with Kate Boddy, who is at Exeter University. And they also have an annual forum where all of the ESG directors come together. That's organised by the ESP, and we have 6 monthly informal meetings, which have been instigated by the ESGs themselves. So we've got lots of opportunity for collaboration as well. Julian.
Okay, so we will say a little bit about the projects we've been doing to date. I hope you'll be a little bit interested in those. There have been 3 over the first year. The first one, and the only one that's completed, was done for NICE as a stakeholder. The second is actually one that we proposed ourselves and they prioritised. And the third is one that's come from the Scottish Government. So rather than read out what's in the slides, all this information, well, apart from the end, I think all this information will be appearing in the slides to come. So this is a summary. Now, the first of them, as you can see there and repeated here, is a diagnostic test accuracy review on rapid point of care tests to distinguish between bacterial and viral suspected acute respiratory infections. And this was done, this main stakeholder here was NICE on behalf of the NHS, because the NHS wanted to planned their strategy for dealing with suspected ARIs what was this last winter. And they introduced these ARI hubs, the idea of trying to concentrate management for people with suspected ARIs in particular places like GP surgeries or other community places, or even in hospitals. Anyway, they wanted some guidance based on the evidence as to what they should do quite broadly. But they wanted it really quickly because they wanted to publish their guideline in October 2023. Remember, this was back in March, April 2023. And so they approached 3 of the ESGs with a suite of reviews to inform this guideline. And we were one of those 3. And the review that we were given was this diagnostic review. And we worked out that we could, well, actually, we had to do it in 3 months. And we worked out that we had 120 person working days because we didn't have a full complement of staff at all. And so here you can see the guideline as it was planned at the time, basically about the initial management of people presenting with suspected ARIs. So work started on this on day 1 of the project, and we'd even started discussing it with NIHR before we formally started it in ESG, such was the urgency. So we worked on a protocol that we submitted 3 weeks or so into the project. It took actually quite a while to get sign-off of that protocol because we were also kind of interdependent with the other 2 ESGs working on parallel reviews, which I'll show you in a second. Got registered as soon as it was signed off and was published 10 days later. We worked on the review. We were already working on the review, hoping that our submitted protocol will be approved. And so we managed to complete the review on time by the 30th of June. And it went to the committee a couple of weeks later, and we submitted an expanded version for formal publication in the NHS General Library at the end of July. Actually took a very long time for them to provide peer review comments, which we did get and we've received, but it's still not published. But that said, the evidence was published by NICE alongside the guideline, well, in fact, before the guideline, presumably in a consultation. So all the evidence that we identified was fully published very soon after it was done. It's just the academic publication has taken a long time. And the image on the right is of the protocol that was published on the NIHR website on the 26th of May. So ours is the review on the right here, and this just shows you what the other 2 reviews were that informed the same guideline. The York group looked at a kind of some prognosis type review, looking at signs and symptoms and early warning signs, which of those predict severe illness, so need to be used for that. And the middle one was looking at the effectiveness and essentially cost effectiveness of the tests, the same sort of tests that we were looking at, whereas we were looking at the diagnostic accuracy of those tests. I think we got the shortest straw here. The other 2 were a little bit more challenging than ours, but we all had this very tight timescale. So just one quick summary of what we found in this review. Our methodology was primarily an overview of reviews, given the time frame, but where we didn't find systematic reviews, we did do de novo searches to find primary studies. So as a reminder, what we were looking at were point of care tests or symptoms or signs trying to distinguish between viral and bacterial infection. So these could be things that generally try to diagnose bacterial infection on the assumption that anything else would be viral, or those trying to generically diagnose viral infection on the assumption that anything else would be bacterial. Or there were some that were really trying to distinguish between genetic, bacterial, or no infection. We also looked at a couple of specific viruses that were expected to be very common in flu and RSV. In all of the studies, our reference standard could be anything, but often it would be a culture in a lab. We looked at remote or face-to-face settings. Obviously, those involving samples would have to be face-to-face. So as it was an overview, we used tools like Robis to look at the quality of the reviews. And when we looked at the primary studies of test accuracy, we used Quotas 2, and we used grade as normal to pull things together. So it was submitted. Very quickly, we found 23 reviews that met our criteria, but when we looked for those that were most comprehensive and up to date, we narrowed everything down to 6 that contributed data. Sadly, the level of evidence was not very high, and we didn't find any remarkably wonderful things. The symptoms and signs, predictably, were not particularly useful to distinguish between them. Accuracy of host biomarkers, not really sufficient, although combinations of biomarkers seem to be better. And for the particular 2 viruses, 2 types of viruses we looked at, there was some benefit of those, particularly using nucleic acid amplification techniques. Okay, we're not really here to talk about the review findings so much, so I'll pass on to Debbie to tell you a bit about the how the second review came about and what was it for.
Thank you. So in contrast to the review that Julian was just talking about, which was, I think, had person working days estimate of about 120, our second project was an ESG proposed project. And we costed that at 330 person working days over a 10-month timeline. It was proposed by one of our academic collaborators, and was a broader question actually than what we settled on in the end. But the research question we settled on was, what is the comparative effectiveness of non-pharmacological stress management and relaxation interventions for improving outcomes in hypertension and pre-hypertension? Next slide, please. So our eligibility criteria for this review, we focused only on randomized controlled trials and on adults who had a diagnosis of primary hypertension or who had blood pressure measurements in the pre-hypertension range. Now, after consultation with our public contributors, so Andy has a wide network of people who are interested in getting involved in systematic reviews and contributors, and we recruited 4 to help us with this review, and they indicated that their preference would be to carry on with their medication, their antihypertensive medication, not to come off that in order to have access to relaxation interventions. So their contribution directly informed our decision to include patients who were still taking medication in the studies. Eligible interventions were any non-pharmacological intervention where there was the specific intention to promote relaxation or reduce stress, and we included both passive and active comparators. Next slide, please. We proposed a network meta-analysis as the analytical approach for this project. Our scoping suggested that there were going to be 11 intervention categories of interest in relaxation and stress management. And we estimated from that scoping somewhere around 170 studies, but we had quite a wide range, could have been as low as 130 or as high as 210. Our primary outcome was systolic and diastolic blood pressure, but we also included additional outcomes around mortality, cerebrovascular events, ischemic heart disease, heart failure, and so on. And that was as a consequence of reaching out to our policy and practice advisors. And in recent clinical guidance, it had been suggested that the outcomes of interest were more directly impacting on patients. So we wanted to look for these, I guess what we might call harder outcomes rather than surrogate outcomes like systolic and diastolic blood pressure. And we did that as a consequence of reaching out to policy and practice advisors. And we included outcomes up to 3 months as short term, then we had medium term and longer term durations. Results so far, we're partway through. We've got a couple of months left. Our deadline is the end of June, and I think we're on track for that. We found 183 studies, of which 142 were in hypertensive patients. The sample sizes, you can see here from the lovely graph that my colleague Monica has drawn for us, that there's the sample size is somewhat skewed, and the median sample size was only 59. We've got studies dating back to the mid-70s, and the majority of those studies, the 183 studies, were from the USA, followed by China and India. Not every study reports diastolic or systolic blood pressure, but somewhat disappointingly for our policy and practice colleagues, only 3 of those 183 studies reported any other outcome other than blood pressure. So that is disappointing. And then there were lots of different measures of blood pressure, different locations and different approaches to measuring blood pressure. 48 of those studies reported multiple time points, and we were interested in doing some, potentially anyway, some simultaneous analyses of these multiple time points and simultaneous joint estimation of diastolic and systolic blood pressure. We're about a third of the way through our risk of bias assessments, and 35 of those 60 or so that we've extracted are at high risk of bias for at least one of those 3 time points, and 25 are at some concern. So this isn't a this is a literature with small studies that are largely at high risk of bias. Next slide, please. One thing we weren't quite prepared for, the scoping did not prepare us for, was the plethora of different types of interventions. So we've spent quite a lot of time trying to use the published studies to classify these interventions. So even though we anticipated, for example, that we would find biofeedback interventions, we weren't so aware that there were, we might find 5 different kinds. So this has been quite time consuming trying to piece all of this together. But I think 6, 9, our estimate of about 11 intervention categories wasn't too far off. We've got 10 on this slide, and we do have one more that we called multi-component. Oh, is it? No.
It's counting.
Is it 11? You're the statistics lead. I will defer to you, Julian. Next slide, please. And just because we all like a picture, this is what our initial network plots look like for hypertension. You can see that we've got lots of comparisons, but not many studies making each of those comparisons. And next slide, please. And for pre-hypertension, it's even more sparsely populated. And indeed, some of the comparisons on the right-hand side there, we've got diet versus a diet plus music therapy intervention that's not connected to our network at all. Next slide, please. So we are just about to start the analyses. Our primary analysis was only going to be on studies at low risk of bias, which is not looking very promising at the moment on the basis of 60 of our studies having been classified at high risk or some concerns. And And we planned to do analyses at each of the 3 time points, and for diastolic and systolic blood pressure separately, and indeed for the 2 populations separately as well. So we're making progress there. We also had subgroup analyses planned, and a range of sensitivity analyses. And the last little graph there at the bottom right is, again, Monica has beautifully drawn it. And it was just to illustrate that we're pleased that we took on board the public contributors' advice along, including participants who were still taking medication, because the left-hand graph is showing that for the hypertension population, around about 35%, 35 of the studies, all of the participants in those studies were taking medication. About 45 of those studies, most of the participants were taking medication, and so on. We've got about 28-ish that none of the participants were on medication. Unsurprisingly, it's not. We don't see the same picture in pre-hypertension, but we feel by including those studies where participants are taking medication that actually the impact and the policy and practice relevance of this piece of work may be maximized. Is it over to you, Julian?
Yeah. So our third and last project that we've been working on in any great detail is quite a different one again. It's about the effect of sunlight on mortality, as it's an exposure outcome question. Basically, this came from the Scottish government because the guidance around going out in the sun is universally pretty much to stay out of the sun. And apparently our guidance is very much based on the Australian guidance, where the issues are somewhat different from the issues in Scotland, where the sunlight is rather weak and doesn't come out all that much. So there's a particular professor in Scotland who is very interested in the beneficial effects of sunlight and has been doing quite a lot of research in there. And the theory he's working on mostly is its beneficial effects on cardiovascular health because of its reduction in blood pressure, right? Yeah. And so he went to the government and asked them to do something about it, and they came to us to commission this. Well, they went to the ESG, the evidence synthesis program, who came to us as an ESG and asked us to do a systematic review. And we costed this one at 303 person working days over a 10-month period. We found more studies than we predicted, so we managed to negotiate a 2-month extension, which will take us to the end of June. We're looking at studies in the general population using any sort of measure of sunlight exposure, including those based on radiation, UV measures, but also those based on very much proxy measures or indirect measures, such as your geographical location on the planet, or latitude, or occupational measures of exposure. They have to be associating these with either overall mortality or some type of cancer mortality or some type of cardiovascular disease mortality. And we're looking for any sort of epidemiological study design, case controls, cohorts, ecological studies, or controlled trials if they're out there. It's, as I say, a standard systematic review in the area of etiology, and we're planning meta-analyses mainly for the radiation-based exposures that we found, but then secondary analyses looking at whether there's any additional information in these proxy exposure measures. One of the challenges in this is that a lot of the studies are based on national databases, looking at death rates or cancer rates and information about radiation in different parts of the country. And there's potential for overlap, of course, when different authors, or even the same authors, use the same database for different analyses. So we've been looking out for that. Very quickly, what we've found so far, we've found 73 studies, mostly ecological. Only 43 of them are likely to contribute to meta-analyses. They range hugely in their time, from published in 1941 up to last year, cover a reasonable span of the world there. And luckily, we've got a fair number that are using radiation-based exposures. So that's 54 altogether, and 19 of the studies only looking at proxy exposures that we may or may not make much use of. Okay, so we're nearly done there. Just a little bit to bring us to a close, just to say that if you want to read more about our evidence synthesis group, we've got a website here. You can see the URL, which we'll be happy to share, or they were easy to find, I hope. We also have, what's this, an X or something? I don't use Twitter or X, but Debbie could say more about that. I don't know if we're being very active because we haven't had all that many outputs yet. And the very last thing I wanted to say is that this program of the ESGs seems to be very well received. And NIHR recently announced 2 more ESGs they want to fund. And there's a call just been put out in the last few days looking for 2 more evidence synthesis groups, focusing specifically, one on living systematic reviews and one on screening, National Screening Committee. And this is the advert for the National Screening Committee one. I think that's all we had to say. We're very happy to answer any questions. I hope that was the sort of thing you were interested in when I gather you were interested in learning about what the ESGs were up to. So I'll close there. Thanks.
Great, thank you, Julian and Debbie. We have a manageable sized group here, so I would say just feel free to unmute if you have a question. And I'll start us out with one. As a librarian information specialist, I'm interested in how that key role is integrated into the ESGs. You know, how are they chosen? How does funding work there? Anything you can say about that? This we advertised this webinar to several medical librarian groups. So I think there's several medical librarians in on this webinar.
Yeah, I just noticed Carol is here. Hi, Carol. And maybe others I can't see. So EGSG would be expected to identify their own information specialist support. What we did, we just, in our application, we said, well, we're going to fund 2 days a week of one of our existing information specialists through this, and she will support all the reviews done in our ESG, and it's working out very well. I would expect all of the other ESGs have done something very similar.
Great, thanks.
So there was a question in the chat about studies within a review. I can, well, hopefully I can share my screen. Hopefully you should be able to see something called the SWOR store.
Sorry, Debbie, can you repeat the question? It may have went to you personally.
Yeah, apologies. Okay. Oh, yes. Could you give a quick definition of I never know whether to say SWOR or SWAR. I think
Swear.
Exactly. Either way, it's present tense or past tense. So a study within a review is a study within a review. I think the reason I shared my screen is because the simplest way to define it is to give you some examples. So when we're doing big systematic reviews, we're very often making smaller methodological decisions along the way. And one example here is the first study within a review. This repository is managed by colleagues at Queen's University in Belfast, and that's where the co-lead of the methods working group, Mike Clark, that's where he's based. And he oversees, and his colleagues oversee this enterprise. So for example, the citation screening. So a study within a review, a protocol, a proposal was put together to compare two different approaches to citation screening in systematic reviews, and a bit of a time and motion type of study. So I'm not sure if you are still on the main repository screen, or if you can now see.
You can see SWAR 1 now.
The detailed outline. Thanks very much. So much like putting together a protocol proposal to be registered on something like Prospero or Open Science, this repository of studies within a review, you put together an outline, a proposal of what your study within a review is going to look like. It's not just you that can, it's not just the person who's proposed the study within a review that's able to carry it out. Others can, and in fact that's encouraged, because the more people who apply these studies within a review, the better. So this one, the objective here was to evaluate the effects of two different methods of screening, sequential screening or simultaneous screening. I'll put the link in the chat just so you can all have a look. But we also proposed one as part of the hypertension review that I've just illustrated. And we were looking at the time and resource implications of reviews with network meta-analyses. So it's often said that network meta-analyses require more resource and take longer. So we thought we'd have a look at that. It will only be one case study. And so actually you can see the more people who implement these, the better. I will stop sharing.
So I see a question from Guillaume, whether we have specific funding in our ESG for methodological development. We do not. So if we face methodological problems such as a type of data that we don't have quite the right statistical methods, we don't have funding for that. The only thing we are funded to do is that within our existing funding to do the evidence syntheses, we are encouraged to do these SWARs that Debbie has just talked about. They're the only methodological research that they would encourage us to do. So answering new problems, no, but answering questions about uncertainties over existing problems through SWARs, yes.
Okay, thank you very much.
Well, I have another question. As someone who participates in a formally organized systematic review service, how do you track do you have to track the person days for these projects, or do you just estimate? Do you have to do a final follow-up, or how does that work?
You want to take that, Debbie?
So to date, NIHR haven't asked us if we've under-costed. No, over-costed. That's the way I meant it. So we haven't been asked to give them back any of our allocation. And as you'll have seen in Julian's presentation, where we have undercosted or our scoping was misleading in some way, we are able to go to NIHR and say we need a bit of extra time, and here's the the detailed reason why. So we're not they're not monitoring us in a a Orwellian way. Great,
thanks. We have kind of an informal method of just tracking time for individual librarians, just so we know how much time we're spending. And it's more like probably for advocacy. You know, do we have enough resources for the demand that we have, and how much time are we spending? But yeah, I was just curious. Yep, thanks.
I think it's really challenging. I mean, I have personally found it quite challenging to accurately cost, because each review can be so different, and the challenges that you might come up against, even for a network meta-analysis, can vary by topic or by size of the literature. It is somewhat challenging.
Yeah, it is a bit unclear how much our information specialists, whether the 2 days a week are about right. Our information specialist works 2 days a week for the ESG and 2 days a week on other things. But we also, as a department, have lots of people doing systematic reviews who ask for little bits of help. So that are unfunded. So it's to our advantage as a department that we've slightly overcosted that, but I just don't know whether we have, and I don't really want to know, because they're so valuable and so important, as you know, and so sometimes a bit difficult to fund their time. If we've got some solid time funding, it's immensely valuable to us.
Great, thanks.
Hi, I'm Caroline. I'm calling in from Ontario Health in Canada. It was a really great, interesting presentation. Thank you. I was just curious, and I may have missed it. Where are the final reports being deposited? I'm also information specialist. When it comes to searching for the evidence, we have, you know, our traditional databases and then looking in the great literature. So if I missed it, my apologies. But I was just curious.
No, you didn't miss it. We didn't say that. The request from NIHR, the funder, is that each of our evidence syntheses is published in their journal, the NIHR Journals Library. Now, as you saw from our first example, at the moment there is quite a long turnaround there. And so that's quite problematic. I hope that'll improve when they get their system sorted out that they're transitioning through at the moment. But we're allowed to send to other journals if we think there's a good reason to do that. Now, we expect that most of the time we'll want to send to a journal that is either more high profile or more relevant to the individual systematic review to try and reach a bigger audience. So it's difficult to predict quite how often we want to. But we've got a definite home in the NIHR Journals Library as long as we do a good enough job, and the option of publishing elsewhere instead, but not as well as. And some of the products will get published by the stakeholder. So when we work for NICE, I hope you all know what NICE is, the National Institute of Clinical and Care and Social. National Institute of
The Health and Care Excellence.
Health and Care Excellence.
They're our health reimbursement organisation. Any treatment that is allowed to be available on our National Health Service has to be assessed by NICE.
Yeah, so they published our results early, and other stakeholders may well get a report from us that they disseminate in other ways, in addition to the academic publication.
Great, thank you. I mean, you're talking about the post-report production. I'm in health technology assessment, and we do things quick, but then when it gets to, you know, finalizing and approvals and all the rest, it's another several months after.
Indeed. All the protocols for our evidence syntheses get published on the NIHR website once approved. And in Prospero. Well, the records in Prospero, the protocols on the NIHR.
Okay, are there any final questions? Well, thank you, Julian and Debbie. Very interesting, informative presentation. Again, we will be making this recording available in the next day or so at the link I just put in the chat again. Sorry, I keep putting it in there, but if you join late, you can't see the chat before you join. So put it in there multiple times. I will stop recording and we will end the webinar here.